as a respectful sign to our presenters. Everyone good? Sweet. All right, here's Laura again.
Okay, so this is a student-led presentation competition, and our first presenter is Colton Bush. So give him a warm welcome.
One last thing is that student reps, please be mindful and please pay attention because your feedback will be needed in the future. And students, also give all your feedback to your student reps for voting. Colton, the floor is yours.
Hey guys, can you hear me okay? Yes. All right, so first of all, I'd like to say it's always hard being the first person, so bear with me here. But my name is Colton Bush, and I'm going to be sharing a little bit with you about ACL reconstructions with quad tendon autograft. So we're going to break it down real quick into a couple of categories. We're going to have some history. We're going to talk a little about who conceptualized the idea, who was the first to perform the actual surgery, and then move into a little bit of the anatomy and physiology, followed by some signs and symptoms of an ACL injury. And then we're going to break down the surgery, post-operative care and risks, and finally a case study about a 25-year-old female. So a little bit about quadricep autograft history is that it was first conceptualized by Dr. Hayden A. Marshall in 1979. He first decided, hey, instead of using a hamstring tendon or a patellar tendon autograft, I'm going to use a quadricep tendon. So he combined a quadricep tendon as well as fascia over the patella and the patellar tendon, fused them together, and used it in the first ever, what he called quadricep tendon autograft. Later, about 7 years after, in 1963, Dr. Yasada K. and Dr. Bluff W. decided we're going to do a full-on quadricep autograft tendon surgery. So they actually took a full segment of the quadricep as well as a bone plug and used that in the first ever ACL reconstruction of the quadricep tendon. A little bit about the advantage of a quadricep tendon versus that of a patellar tendon or hamstring tendon is that the quadricep has a larger and wider anatomical area. It's bigger than that of what we would see in the patellar tendon or the hamstring, or as they professionally call it, a semitendinosus graft. So it has a larger anatomical area, and therefore it's going to be longer, wider, and stronger when used in grafts, or so our research has led us to believe so far. It's also going to have greater strength compared to those of a patellar tendon graft. I'd like to note that autografts are different than allografts. Allografts are used for people that are older, and they're going to take that graft and use it from a cadaver, and autografts are going to be from your own body. So we're going to take the quadricep tendon, and we're going to reconstruct or replace that in yourself, so the reconstruction is coming from yourself and not from someone else. So I found a Denmark study that was between 2019 and 2021 highlighting and comparing a quadricep tendon autograft versus that of a patellar tendon as well as a hamstring tendon, and kind of broke it down into these numbers concerning re-rupture rates, complication rates, as well as the use of the graft. Looking at first glance, I'm not going to read all the numbers to you, but you can tell that quadricep tendon have the least used graft out of all three. But they also have the lowest re-rupture rates as well as the lowest complication rates, which, based off your logic, you'd assume, why aren't we using more quadricep tendon for our autografts? Well, if you think about it, only 3% are used, so we have a pretty small sample size, so we can't 100% rely on our data for re-ruptures and complication rates, so we don't know 100% for certain if quadricep tendons are better than that of what we consider the gold standard, which is a patellar tendon graft. So a little bit about the anatomy and physiology. I hope you all know where the ACL is, but it's located in your knee, for those of you that didn't know, and it's one of the 4 stabilizing ligaments, including the PCL, MCL, and LCL. And it's there to help stabilize your body so you can stand and move and feel stable in your movement. The ACL, when having a complete tear or rupture, is not going to heal on its own. You're going to need an outside reconstruction or replacement for it. So an ACL reconstruction with a quad tendon autograft takes part of your quad tendon, removes the injured ACL, and completely replaces it or reconstructs it for your use. Now we're wondering how you injure your ACL. Well, that's going to come from a variety of ways. There's non-contact ways and contact ways. The most common you'll find is the non-contact, and that's going to come from a sudden change of direction, or if you're running really fast and instantly decelerate, followed by jumping and landing awkwardly. And a contact way that would occur is if you're hit from the lateral side medially. So if a football player hits you from the side of your knee inward, and you're going to have a valgus force acting on your knee. And the most optimal position for injury is going to come with your foot planted. You're going to have knee flexion, knee valgus force, and a hip internal rotation, and that's when you're in the most prime position for injury. Short story about my uncle. He's an old guy, just for reference, and he bought a trampoline for his family. And you know, kids love trampolines. My cousins, they love the trampoline, and my uncle decided, I'm gonna give a go on the trampoline. So he started bouncing, and he tore his ACL pretty badly. So he went through a surgery, got it reconstructed and replaced, all because he landed badly and had that prime positioning for injury. And as soon as he got back from his injury, which he's still recovering from to this day, he took that trampoline apart and sold it instantly. I'd like to note that some of the symptoms you'd experience if you injure your ACL, you're gonna have swelling due to bleeding in your knee joint, as well as you're gonna be unstable in your movement. You're not gonna be able to move and walk around as easily as you once were. You're gonna feel unstable in everything you do in your day-to-day life. And that's where we're moving on to kind of the procedure of what the surgery actually is. And I'm not gonna spend much time because it's very similar to other autograft surgeries, but basically it's gonna be a minimally invasive arthroscopic surgery where they're gonna cut incisions into the left and right of your knee or the lateral and medial sides of your knee, and then pump your knee full of sterile solution to expand the knee joint as well as to clean it out. And from there, they're going to remove the injured ACL, and they're gonna replace it with a 7mm by 2mm segment of your quadricep, and they're gonna screw it in place, and bam, you got a brand new knee for the most part. Of course, coming with that, you're gonna have some post-operative care and risks. Starting with that is gonna be pain. You're gonna be hurt, you just came back from major surgery. There's gonna be pain management through medication, as well as you're gonna wanna do price. You're gonna wanna protect, rice, isolate, everything that you need, compression and elevate, followed by, there's gonna probably be a knee immobilizer involved. You're gonna want to keep your knee locked tight so that it can heal over time on its own with your new reconstruction. And from that, it's gonna take 6 to 8 weeks before you can return to normal day-to-day activities like walking and moving around after your knee immobilizer is off. And you're gonna wanna be attending physical therapy for weekly up until you're returned and fully back to your healing self you were before. I'd like to notice, as most surgery, there's risks associated. For this one, there's some big ones. You're gonna have infection potentially, deep vein thrombosis. You're gonna have pain, numbness, tingling. You're gonna have blood vessel damage because you have major arteries running through your leg. Potentially, if that gets injured or cut in the process, you could bleed out. There are a lot of injuries and things that could happen, but risks are associated with all types of surgery. So I wanna talk to you a little bit about a 25-year-old female. She was playing soccer when she injured her left knee. She made a sudden movement, and she heard a popping noise and felt a snapping sensation in her leg. It turns out that she tore her ACL, but she didn't decide to do anything on it. She just felt unstable. She had a little swelling, so she ran around her day-to-day life for about a month until finally she decided to go check out the doctor, and they gave her an MRI. And you can see the small MRI on the screen. I'm gonna go ahead and blow it up for you. And if you go ahead and look, I labeled some of the key parts, and in the circled area, that is the ACL. You can note that it's distorted. It's kind of a blob, so you can't really tell what it is. Well, on the PCL, you can kind of see small clear attachments to the tibia and the femur. The ACL is kind of just there and distorted, and you can't tell. So the doctors decided to diagnose it as an ACL tear. She also had a lateral and medial meniscus tear, but I'm focusing on the ACL because she decided to have it reconstructed using her quadricep. So the doctors went around the surgery that I told you about. She had her surgery, and she went into her care because she wanted to return to soccer 8 months later. So she was in a knee brace for 8 weeks. So she got back to her normal day-to-day activities in 2 months. And then her knee healed quicker than others, and she returned to sports in about 7 months. Usually it takes 8 to 9 or longer, depending on who you are. And I'd like to note that she was active on her physical therapy. She was doing it weekly. She was working on her exercises, and this could be leading to her steady recovery and her improved recovery over that of others. And then I finished it off with some citations, and thanks for listening to my presentation. I appreciate it, and if you have any questions, I'm willing to take them.
Can we give it one more up for Colton? Who's next? Seaholm, are you ready? It's locked, so I can't get to it. What's the, yeah, go for it.
Why does it say the speakers are still there? I edited those out.
It's fine. We just won't play them.
Good?
Yeah.
Hopefully.
Okay. Hi. Hello.
Alright. Why? Okay.
It's
Okay.
technical difficulties.
Even more.
Oh boy.
Okay.
There we go.
There we go. All right. Hi, everybody. My name is Chloe Rapay.
My name's Lex Clark, and this is our presentation about juvenile idiopathic arthritis.
So, some of you may be thinking, what the heck is juvenile idiopathic arthritis? JIA is found in 4 to 16 in 10,000 people throughout the US. It is the most common type of long-lasting or chronic arthritis appearing in children before they turn 16. JIA is an idiopathic disease. Idiopathic means that the origin of the disease is unknown. It also means, one second, I can stop. Okay. It also means that the disease is different from everyone depending on really just what different sports you do, what type of body type you have. It really all just depends. Like majority of arthritises, it causes inflammation in joints.
All right, so I actually have juvenile idiopathic arthritis. I got diagnosed at age 7. I've been kind of like thrown in and out of doctor's appointments, and just for a while no one really knew what was going on, and it was just pretty bad. No one could really like tell anything at all, and we didn't know what was going on. And I'm a competitive cheerleader, so I kind of always felt like I was just falling behind with my team because they were all able to do so many things, and I couldn't, just because my knee was swollen and I was unable to move it. And recently I recovered from having a flare-up. I caught COVID a few months ago, and some research I've done, just like talking to my doctors, juvenile idiopathic arthritis and COVID-19, once you catch COVID, it kind of like helps inflate your knee some, or wherever you have arthritis, and it got really bad.
So we're going to look at what can cause JIA. Research has shown that JIA is caused by the immune system mistakenly attacking all of the healthy joint tissue and cells that are in your joints. I guess I already said that. The reason that the immune system is attacking the joints is still unknown. We've tried looking into it. I'm sorry, I don't know what's going on. But it's really hard to find information on. It's just kind of unknown at the moment. But they believe that the main contributing factors are the environmental factors and genetics.
All right, so some of the symptoms of JAA, or just like arthritis symptoms in general, are like swelling and inflammation in the joints, limited movement, or just stiffness in the joints due to like swelling, because it makes it a lot harder to move. There's oftentimes warmth and redness of the arthritic area, and there's often a lot of like pain, especially after you haven't like moved for a while, so when you first wake up. And then some JAA specific symptoms are like growth or developmental problems, skin changes such as like rashes or a scaly texture on your skin. You can get damage to your organs, and inflammation in the eyes causing loss of sight. So usually if you have JAA, you're kind of going to the eye doctor at least 3 times a year.
JIA is treated with, most of the time it's physical therapy, and if it gets to a certain point, it's treated with anti-inflammatory oral painkillers. So there's several different medications you can take, but such as like corticosteroids and biologic response modifiers. It'd be great if it would stop doing that. So yeah, those are the main 2 treatments.
JAA is diagnosed in a series of tests, because there's nothing in particular you can use to diagnose just any type of arthritis, because joint pain can be caused by a ton of different things. Just like overuse and stuff could also show up, not as arthritis or anything, but it can just show up as joint pain. So a lot of like blood tests and stuff are used to rule out any other options of juvenile arthritis. So you kind of like, yeah, it's basically a process of elimination. And then my treatment process has been a variation of like different medications. I've had fluid drained out of my knee, and it's been pretty bad. It's not the most comfortable feeling. It's a very thick needle. I'm sorry to those who are afraid of needles. and then after I get fluid drained, I get like steroid injections, and it helps for a bit, but I also can't do any activities. And then I used to take meloxicam, which is a non-steroidal anti-inflammatory drug, but I eventually got an immunity to it, and it no longer worked on me, which was awful because it's one of the least harmful drugs you can take. Dang it. And then recently, once I had another arthritis flare-up, I moved on to naproxen, another anti-inflammatory drug, and methotrexate, which is a chemotherapy and immunosuppressive drug, which I take as a weekly shot. The naproxen I no longer take because it was something before the methotrexate had like built up in my system. And yeah, I just have my mom give me weekly shots instead of going to the doctor constantly, which is nice. And usually once I get a pretty bad flare-up, I'll also have to take like oral steroids, and just it gets bad, but they help a lot. Thank you for your time.
Bye, everybody.
Can we get another round of applause for them, please? Which one? Edmonds Woodway. Okay, so this needs to go. That needs to go. That needs to go. Which one is it? Alright. Oh wait, I think it's. Yeah, Edmonds Woodway hits too. Where is Edmonds Woodway? Yeah. Yeah. Theirs was like on a timer or something, which is the problem. So like it was like a Google slide where each slide had a timer or something. But this one doesn't seem to be doing that, which is weird. True. Yeah. And there's had speakers, so. They had like it was like. So did I. No, like they can have it if it's PowerPoint. They can have it like read out to you. It's so weird. Okay. You wanna? I don't know where it is.
Give it a second.
This thing hates me, honestly.
What does it say?
What does it say? Is it air filter?
It feels really full. What does it say?
Do we have to go straight after this to our tests?
Stop.
You're laughing. You're gonna make me laugh.
It's not my computer.
Well,
It's not my computer. It's the. I'm saying it's the cable, not my system. Oh. No, it's downloaded.
when I signed up,
Do you think it's the computer? Or you think it's the cord? There it is.
yeah, that's exactly.
We got it.
Oh, wrong. No.
Yeah, I saw it. This thing hates me.
But it does that when it's supposed to be.
Sorry, you guys.
No worries.
Not gonna touch. You want to introduce them?
Give a warm welcome to Edmonds Woodway.
Hi, I'm Jalen,
I'm Ella.
and today we'll be talking about unintentional anorexia.
So what is it? Anorexia nervosa within athletes that's not intentional is also called anorexia athletica. Athletes with anorexia are more prone to muscle and bone injuries, nutritional deficiencies, and no menstrual period. People with anorexia athletica take in limited number of calories despite a high level of physical activity. People with anorexia athletica have lost at least 5% of their healthy body weight due to calorie restriction and excessive exercise.
So, who is most at risk? Usually people who are in sports that ask for leaner or smaller bodies or lower weights, or sports that need a certain weight. Dance, track, cheer, ballet, wrestling, cross country, and boxing are some examples. Many don't see their anorexia as unhealthy, but see it as helpful in their sport.
So some of the symptoms include restricting calorie intake, low energy, fatigue, trouble focusing, dizziness or lightheadedness, irritability, more frequent injuries, longer recovery time, high physical activity, focus on performance, and many times those with anorexia athletica are related to distorted to idea of their body image.
Some possible causes are pressure from others, such as coaches, teammates, trainers, media, family, and friends. Meeting certain criteria or judging criteria, weigh-ins, and tight or revealing uniforms.
So a big part of this is prevention. So the first thing, you should take warning signs and eating disorders behaviors very seriously. Cardiac arrest and suicide are the leading causes of death for people with eating disorders. If an athlete is chronically dieting or exhibits mildly abnormal eating, refer to him or her to a healthcare professional with eating disorder expertise. Early detection increases the likelihood of successful treatment. Left untreated, the problem may progress into an eating disorder. De-emphasize weight by not weighing athletes and eliminate comments about weight, instead of focusing on the areas which athletes can improve on performance. For example, focus on strength and physical conditioning as well as the mental, emotional components of performance. Don't assume that reducing body fat or weight will enhance performance. While it may lead to improved performance, studies show that this does not apply to all athletes. It is not uncommon for individuals attempting to lose weight to develop eating disorder symptoms, which can physically weaken the athletes. Performance should not be at the expense of the athlete's health. Instruct coaches and trainers to recognize signs and symptoms of eating disorders and understand their role in prevention. Eating disordered individuals often hide their symptoms out of shame and embarrassment. Provide athletes with accurate information regarding weight, weight loss, body composition, nutrition, and sports performance to reduce the misinformation and challenge unhealthy eating practices. Emphasize the health risks of low weight, especially for female athletes with menstrual irregularities or amenorrhea. Risks include low bone density, lowering of immunity, and autoimmune illnesses. Understand why weight is such a sensitive and personal issue for many men and women. Eliminate derogatory comments or behaviors about weight, no matter how slight. Celebrate the athletes for what the talents and strengths beyond the physical look.
How do eating disorders differ between males and females? Males and female athletes with eating disorders share some similar characteristics that are common in the sport environment: competitive nature, driven by performance goals, committed to sport, extremely disciplined with training and diet. These interpersonal characteristics can also fuel an eating disorder or exercise disorder. When an athlete is under stress or has a predisposition to mental health conditions like anxiety or depression. Other stressors like academics, finances, scholarships, relationships, and sports injuries increase an athlete's vulnerability. Athletes are more likely to underreport their symptoms and or consider them to be benign, perhaps even required in order to be elite. The tendency to recognize eating disorders in females more readily than in males, and to recognize anorexia nervosa more readily, which makes the detection of eating disorders in male athletes more challenging. In general, males with eating disorders tend to have a worse prognosis than females because they tend to wait longer before they come into treatment. By the time they seek help, males are often sicker and have more serious health consequences. We need to do better about raising awareness and identifying risks in males.
Are eating disorders more common in a certain age group? From clinical trials, it's really important to not discriminate against eating disorders. They affect all genders, a variety of racial ethnic groups, and occur in all sports. They occur in adults, adolescents, and now in children. Stereotypes and stigma that depict eating disorders only as underweight adolescents, females, females but not male athletes, or athletes only in lean, waist-based aesthetic sports, and misinformed. College-age adolescents and young adults constitute a high-risk category. The life transition to college can involve a lot of stress related to the need to establish a support system and build new relationships. The college setting can increase eating disorder risks related to social expectations, dating, culture, substance abuse and use, academic stress, role modeling, and unhealthy eating or exercise behaviors. College athletes have to manage all of that along with the pressures of competitive sport, putting them in increased risk for an eating disorder.
Here are some common types of eating disorders in athletes.
So most people picture patients with anorexia nervosa as underweight, but that's not always the case. According to a 2019 study, 1/3 of all people admitted for eating disorders treatment are at a normal weight or above. The study followed a group composed mostly of women ages 12 to 24 who had just lost about 30 pounds or over the 15 months. More than half of the age group fell into the higher weight category with a diagnosis officially known as atypical anorexia nervosa. This carries the same symptoms as anorexia nervosa, including restriction of food intake, intense fear of gaining weight, and the disturbance in the way they view their body. However, the group of a normal to high body mass index showed greater damage to their health, both physically and mentally. The study suggests that this may be because of the added trauma and stigma for teasing. So the takeaway here is just because an athlete does not look underweight does not mean they're not at risk.
Healthy eating is key to performance improvements in sport and exercise. Orthorexia, though, is proof that too much of anything can be undesirable. The National Eating Disorder Association defines it as an obsession with proper or healthful eating, though it has yet to make it into the DSM-5, the Diagnostic Reference Guide of Psychiatry. Some common characteristics of orthorexia include compulsive reading of food packaging, cutting out an increasing number of food groups without a medical reason, being unable to eat foods that do not measure up to certain health criteria, and being unusually interested in food overall, including future meals, food blogs, and what other people are eating. Because it is so restrictive, orthorexia may result in malnutrition, so it may impact the body, similarly to anorexia nervosa. Obviously, it also may impact the athlete's performance in sport.
So the female athlete trade. In an opinion from a paper from the American College of Obstetricians and Gynecologists, the female athlete trade is described as having 3 components. 1. Taking in insufficient calories with or without disordered eating. 2. The stopping or distribution of menstruation. And 3. Low bone density. Recently, experts also have identified a condition called relative energy deficiency in sports, REDS, which shares many of the same signs used to describe both men and women. According to a clinical assessment tools in the British Journal of Sports Medicine, signs of REDS includes decreased muscle strength, endurance, training response, coordination, and glycogen storage. increased injury risk, depression and irritability, and decreased concentration and impaired judgment. Clearly, some of these topics can fall outside the realm of discussion out of the sidelines of games or even in the locker room or gym. Fitness professionals who do not believe to apply into the participants' lives beyond sports may not be aware of some of these symptoms.
Exercise dependence, also known as exercise addiction or compulsive exercise. Exercise dependence has been associated with eating disorders and in women perfectionism. While this has been previously noted in women, a 2019 study also found this to be true for male cyclists, triathletes, and long-distance runners. Exercise dependence is characterized as a craving for physical training, an inability to reduce exercise to non-excessive levels, and possible harm to physical and mental health, such as injuries, depression, and damage to social relationships. As exercise participants likely discuss many of these factors with their coaches and trainers, these professionals may be able to spot them and initiate a conversation to explore whether their nutrition or eating are also impacted. That's all.
Yelm, you ready? Yelm's on their own. They signed up for it. They signed up for it. Hey, Lindsay, what's next? Yeah. What? Okay, so how do we set up for that? I can, yeah.
You have the WCTSMA. Trying to. That is your charger. I need the aux. There you go. Plug that in. Place some.
No, I don't. You got it.
I don't have it. Do you have Spotify on your computer?
Yeah. Later.
Give a round of applause for our forums. We have 2 more going at 4. Right now we're hanging out and we're getting ready for our quiz bowl.
Can you hand out the plaques as I announce them? So we've got. Yeah. Yep. Hey, Gary.
Actually, quick change of plans. We are going to be giving away our scholarships right now.
All right.
Can we take it out of the plastic or no?
What's up?
Are we taking them out of the plastic? Or
Yeah, you can take them out of the plastic. So I'm gonna have you hold on to them really quickly. All right, are you guys ready to hand out some money? Okay, so this year We had several applicants for scholarships, and we were able, through some generous contributions from several of our sponsors, able to bump up the total amounts for our scholarships up to $1,000 for each winner of each scholarship. So if you hear your name, come on up. You will be receiving a $1,000 scholarship from various sponsors for our organization, and you will hear their names called here in just a moment. So, for the Anatomage Scholarship, we have Lindsay Blakeney from Wenatchee. All right, and the Henry Schein Scholarship, Zeke Miller from Mount Spokane. Former state officer, Zeke Miller. Our Founders Scholarship goes to Claire Stone from Mount Si. And last, oh, wait for Claire to get up here. Good job, Claire. And last, we have the WCTSMA Supporter Scholarship, which goes to Molly Korak from Yelm. We don't have a Molly right now. She'll be around. We'll let her know next time she comes. So if you would like to get in on this fun for next year, our scholarships generally get posted around December with an application window open until the end of March. So keep an eye out for those scholarship opportunities. We will have more information at Winter Leadership next year for some opportunities to win some money towards college. So congratulations. One more round of applause for our scholarship winners. And I would like to hand off the microphone for our Instructor of the Year award.
It's great to be back in person, isn't it? Yeah. So I get the pleasure of introducing the WCTSMA Gary Hurst Instructor of the Year award. This individual is the yin to my yang. He is my work husband. And also the Clyde to my Bonnie. So the Instructor of the Year goes to Tom Dimmel from Ferndale.